views and opinions expressed on My Story Living with Lupus podcast represents each person's individual experience. By listening to this podcast or reading our blog, you agree not to use this podcast or blog as medical advice to treat any medical condition in either yourself or others. As always, consult your own physician for any medical issues that you may be having. My Story Living with Lupus podcast is officially trademarked, all rights reserved. Welcome back to another episode of My Story Living with Lupus. I'm your host, Susan Hendricks, and I'm so glad that you could join me on this Friday. Today's topic for discussion is, what are the major challenges in 2019 for lupus? Also, we'll be talking about cardiac dangers arise early for minorities with lupus. So, you know what I want you to do. That's right. Grab your cup of coffee, your cup of tea, and if you're listening late at night, you know I appreciate you. Grab your favorite glass of wine and come on and join me right here on My Story Living with Lupus. You know, we all know that there are challenges within the medical field regarding lupus. But what are the major challenges in 2019 in lupus? Despite the striking improvements in survival among patients with systemic lupus erythematosus in recent decades, from 1 year survival of less than 50% before the introduction of prednisone to 90% today in most specialized treatment centers. But many challenges remain in this perplexing and multi-system disease. The University of Strasbourg recently held a roundtable to identify the most important challenges faced today by researchers, patients, and clinicians, publishing their consensus findings online in Lupus Science and Medicine. Now, the assessment and remission factor is a challenge. Now, behind the simple concept of disease activity in SLE hides a complex multidimensional reality where the clinical manifestations attributed to SLE by the physician, the subjective experiences of the patient, and the efficacy of treatments interact all together. The development of disease assessment tools has been a work in progress, beginning more than 25 years ago with SLE, Disease Activity Index. That has been followed by multi-refinements such as the British Isles Lupus Assessment Group score, the Lupus Activity Index, and most recently, the SLE Responder Index. But more objectivity is needed. The authors stated, such as with novel biomarkers that could help identify patients with unfavorable patterns of disease. Advanced methods also should be utilized, including data-driven approaches. Now, 5 years ago, an expert panel recommended that treatment for SLE should follow a treat-to-target approach aiming for remission, similar to what has been widely accepted for other diseases such as rheumatoid arthritis. However, because SLE is a multi-system disorder that typically follows a waxing and waning course, there has not been a widely accepted definition of remission. Now, back in 2017, a framework for defining remission in SLE was published by an international task force which identified 3 principles. The first of which was that remission should be a durable state, although no minimum duration was specified. Remission also should be defined using a validated measure such as the SLE DAI, and a distinction should be made between remission on treatment and remission off treatment. Now, as you know, I've stated in previous episodes that I have not been on any lupus meds for over 2 years now. They took me off of Plaquenil because it was causing more harm than good. So I have not been on any meds to treat my lupus, and my lupus is slightly active at this present time. Now, another group, the Asia Pacific Lupus Collaboration, published a definition of a low disease activity state, which required a SLE-DAI of 4 or lower, a physician global assessment of 1 or less, current daily prednisone dose of 7.5 milligrams or less, and standard maintenance doses of immunosuppressants and biologic agents. They stated that they believe that one of the main challenges is to validate whether these definitions are indeed predictive of outcomes, including damage, death, reoccurring flares, health-related quality of life measures, and whether they can be used as clinical trials outcomes. Now, improving treatment is another challenge in 2019. One important aspect of treatment improvement in SLE will be further limiting the use of corticosteroids, and prednisone is undoubtedly a cornerstone of treatment, but long-term use is associated with serious organ damage, even with low doses. Now, we all know that lupus, SLE, can attack any major organ in the body. And I really don't want to sound morbid, but my sister asked me this question. She asked me, did I believe that the medication that I was taking for the lupus was causing further damage to my internal organs? Would it have just been better off for me not to take anything at all? And I told her at the time that I was in severe, and I mean severe pain, like we all are. And I told her that one or two things: the pain would have took me out, or the medication causing the damage to the internal organs was going to take me out. I could not withstand that pain that I was having whenever I was going, well, when I was having a flare. I told her that type of pain you don't wish on your worst enemy. So I told her that's why I was taking the Plaquenil. And as you know, and as we all know, that there is no cure for lupus, so they allegedly say. And we all have been placed in a position where just for that pain to subside, we had to take something. We had to. But accordingly, the French expert group recommended that future clinical trials include focusing on corticosteroid use, particularly tapering, adverse events, and measurements of damage occur. More therapeutic agents also are needed, and available agents can be better used. In over 60 years, only one new treatment, Benlysta, has been approved for SLE. And I'm going to repeat that. So if you have people telling you, oh, it's not that bad, 60 years. In 60 years, only one new treatment has been approved, and that's Benlysta for SLE. And recent years have seen multi-disappointments, such as Orencia. Some of the failures may reflect a lack of efficacy or unacceptable adverse effects, but many experts also believe that faults also may lie in study design, patient eligibility, and endpoints used. We believe that the current challenges are shifting from whether some new drugs will be available to the identification of the best strategy for the selection of the most adequate drug at the patient level to